Hello, good evening, all Mrcp basis aspirants. We are going to start with the topic today called Spastic Paraparesis. I'm Dr. Moses, I'm one of the medical doctors. My journey with Mrcp was quite long and I've learned a lot of things from my ups and downs. So here I'm going to present some interesting videos for who are all preparing for Mrcp basis. We are going to start with neurology, and I'm building up a website where I'm going to include around, I've come across more than thousands of patients and their videos and the clinical findings and some interviews from consultants from UK and some communication snippets and weekly differential diagnosis and some podcast. All these things will be added upon in the website. Right now, before that, in the meantime, we will discuss some of the topics. We are going to see the topic of spastic paraparesis today, and I believe all of you know what spastic paraparesis is, and we are going to discuss how to approach this as a short case. So the topic is spastic paraparesis. All right, the word spastic means it's a kind of an upper motor neuron lesion. I believe all of you know the features of upper motor neuron lesion, because I'm not going to go into the depth of clinical examination. What are things you will find? So in any examination, typically spastic paraparesis, you will get a lower limb, and in the lower limb, my suggestion would be ask the patient to walk. First, ask to walk. See the gait. Check for Rombergs. If possible, tandem walking. Then ask the patient to lay down. Then see the leg. Inspect for the Mainz protocol, we say. Right. What is Mainz protocol? M for any muscle wasting. I for any involuntary movements. N for any neurocutaneous markers. D for any deformity, and S for scars. And always don't forget to palpate for thickened nerves. Okay, once you have done all these things, once you have done this, next thing, we remember something called TPRCS. Check the tone, which will be increased in spasticity. Check the power, be diminished. Check the reflexes, be exaggerated. Okay, check for coordination and check for sensation. I've done all these things. Well and good. We can now get into spastic paraparesis and its approach. All right. Yes. Here we go. I'll just erase these things in the slide, and we are gonna start from the beginning. Okay. There are a lot of ways a case can come. Okay. I'll tell you what are the differential diagnoses for each, and then we will see some VIVA questions as well. The very first thing, a spastic paraparesis can present as a pure motor lesion. So what you will do if you get a pure motor lesion, there is no sensory findings, but it's a spastic paraparesis. What could be the cause? There are a lot of causes here, starting with HSP. So this is the first case. You're getting a pure motor spastic paraparesis. That is a hereditary spastic paraparesis. You can get a TSP, tropical spastic paraparesis. MND, motor neuron disease. Okay, then you can get this in syringomyelia. Depends on the extension of syrinx. If it doesn't involve the sensory areas, you will get a pure motor finding. Then you can also get parasagittal meningioma. Also you can get in myelopathy. All right, this is a spastic paraparesis with a pure motor finding. All right, now suppose in the next case you are getting a spastic paraparesis. Okay, I'll just mention it as SP, plus you are getting dorsal column signs. Okay, loss or impairment of, what are the dorsal column signs? That is vibration and proprioception. All right, if you're getting something like that, or maybe some Rombergs as well, and you're also getting some Rombergs. So what you can think of, if you're getting a case like that where you're finding some spastic paraparesis and you're getting some vibration impairment and a proprioception impairment with a positive Rombergs, there are a couple of causes. It could be an MS, it could be an SCACD, subacute combined degeneration of the spinal cord. It can be a posterior spinal artery occlusion. You can also get the same thing in copper deficiency. You can also get this in copper deficiency. All right, these are the couple of causes of spastic paraparesis with dorsal column signs. All right, good. Now, if you are getting a spastic paraparesis, that's a third thing. Okay, if you are getting a spastic paraparesis, that is SP, plus loss of pain and temperature, what could be the cause? This can be in three different patterns. First thing, in the form of a peripheral neuropathy pattern. What is a peripheral neuropathy pattern? That is typically of a glove and stocking. It can be with the sensory level, okay, or if there is nothing, no sensory level, no peripheral neuropathy pattern, spastic paraparesis with just the loss of pain and temperature, then it can be anterior spinal artery syndrome. If it is with the sensory level, it could be a lesion in the cord. If it is a peripheral neuropathy pattern with a spastic paraparesis, we can think of two things. One is subacute combined degeneration, other one is your good old Friedreich's ataxia. All right. Okay, guys. Now let's go to number 4. The fourth type of pattern you will get in a spastic paraparesis. Okay, this is spastic paraparesis with cerebellar signs. What you will do? You're getting a spastic paraparesis patient, and you're getting some cerebellar signs. Okay, I got a case like this in the mock examination where she had some coordination difficulty. The examiner didn't allow me to examine her gait. So there are possibilities here. First is a multiple sclerosis. It can be a Friedreich's ataxia. It can be it can be a spinocerebellar ataxia. It can be a vitamin E deficiency. Also, it can be A-beta lipoproteinemia. Alright, all these things can present in that manner. And number 5 is your spastic paraparesis with an atrophy and fasciculation, or could be a mixed LMN and UMN findings. This is going to be motor neuron disease and the differential diagnosis of motor neuron disease, which we will discuss in the topic of motor neuron disease. All right, next, number 6, there are some possibilities of spastic paraparesis. Okay, now you are getting a spastic paraparesis, okay, with fifth cranial nerve involvement. If they ask for namesake, one examiner has asked, I think in Delhi Center, what are the possibilities? It can be a syringomyelia or a syringobulbia, depends on its extension. Okay, if a spastic paraparesis with bulbar weakness, bulbar symptoms, it could be a pseudobulbar palsy, an MND. If there is a spastic paraparesis with optic atrophy plus internuclear ophthalmoplegia, obviously you know your good old MS. If there is a spastic paraparesis with second cranial nerve involvement, it can be a Friedreich's ataxia and multiple sclerosis. All right. Now at this moment you should also know some other findings as well. They will ask you here the differential diagnosis of absent ankle jerk and extensor plantar. If they ask, doctor, what are the causes of absent ankle jerk or an extensor plantar, or maybe you're finding a patient with an absent ankle jerk but his plantars are upgoing. So there are a lot of causes. Few of them: subacute combined degeneration, taboo paresis, Friedreich's ataxia, a case of a myelopathy with a peripheral neuropathy. All these things can cause an absent ankle jerk with an extensor plantar. Okay? Alright. Now, with this, the next thing you should know in case of a spastic paraparesis is a myelopathy. Many myelopathy cases can be easily brought in. Some of them are chronic, waiting for some neurosurgical procedure. If they don't get much cases, they can easily bring in a myelopathy case. Alright? Okay? Always know certain things about myelopathy. This myelopathy can be divided into two types. Alright? Two types. The first type is your compressive myelopathy, and the next type is a non-compressive myelopathy. Alright, this is how we divide myelopathy: a compressive myelopathy and a non-compressive myelopathy. Compressive myelopathy, what are the typical things you will find? You can find a back pain, there's a compression, and you can also find an early bladder involvement, and mostly it will be asymmetrical. Alright, in case of a non-compressive myelopathy, and mostly it can be acute. Most common causes here for a non-compressive myelopathy can be a demyelinating lesion or an infarct of anterior spinal artery or posterior spinal artery. Demyelination, what are the things that can cause demyelination? It can be your multiple sclerosis, neuromyelitis optica, your ADEM, and your transverse myelitis. All of this can cause non-compressive myelopathy. Alright, just a second. Yes, now this compressive myelopathy, which we have seen just now, it can be again divided into two types. First type is your good old intramedullary compression. Next type is your extramedullary compression. Intramedullary compression, before that you should know some basic anatomy of the spinal cord. I believe all of you are good and experts in this. Just for some beginners, I'll just draw some very lame diagram. Okay, just excuse my diagrams. Okay, this is spinal cord. If you take, okay, all right. Okay, this lesion, any lesion here, is called your intramedullary. All right, anywhere here, okay, this is your extramedullary. This extramedullary can be within the dura mater, that's called intradural, or outside the dura mater, it's called extradural. Okay, we'll see some of the causes for intramedullary, extradural, and as well as intramedullary and extramedullary and intradural and extradural causes. Just know the causes, that's more than enough. Okay, this is the spinal cord. Within the medulla, it's called intramedullary lesion. Outside the dura mater, outside this is called extramedullary. It can be extradural if it is outside the dura mater, or within the dura mater, it's called intradural. Okay, what are the causes for this? The extramedullary lesion, like I said, can be classified into intradural and as well as your extradural. What can happen intradurally? Okay, remember a mnemonic called MIA. Okay, What are the causes? Your meningioma, ependymoma, and your arachnoiditis. And extradural causes can be your fracture, okay, your tumor, any mets, okay, or a disc prolapse. Alright, this is the simplified approach to spastic paraparesis. Okay, if you can note it down in a legible way, you discuss with your friends or your PACES partners, it will be very, very fruitful for you. Alright, see some of the cases I have seen during my journey of PACES is, this is one of the spastic paraparesis patient. See here, you can find this clause. Alright, you see, that's me examining. Okay, this is not a proper PACES examination. I just wanted to show you signs. That's it. See here. See the exaggerated angle. See the knee, just a touch. And I suggest you to use this MDF hammer. It's the best one for PACES. Next, see this here. Spastic gait, bilateral. Alright? This is our good old spastic gait. Alright. Okay. Now we come to some of the VIVA questions, okay, that will be asked here in the topic of spastic paraparesis by the PACES examiners and how to answer. Like this, for every topic we are going to see all the VIVA questions without leaving anything. What are the possible questions? Because I have collected from different candidates who have appeared in different centers. Okay, let's see some of the VIVA questions. Okay, let me tell you. There are a lot of questions has been asked. Most of the questions will be answered. One of the most common question that is asked and one of the most common question that is lingering in many people's mind is the differentiation between the spasticity and as well as your rigidity. Okay, the very first point you should know about a spasticity, it is due to lesions in pyramidal tract. Okay, example, a stroke or a spinal cord compression, all these things can cause this. Okay, a rigidity, it is seen typically in an extrapyramidal lesion. Example, anything involving a basal ganglia can produce. Alright, here there are two types of rigidity that you should be aware of. Rigidity, there are two types. First is a cogwheel type of rigidity, another one is a lead pipe type of rigidity. Cogwheel is seen only when there is a tremor, especially you would have seen in Parkinson's disease. Alright, rigidity, there will be a tremor superimposed on hypertonia. Okay, there will be increased tone throughout the movement. Okay, I'll show you some of the videos of Parkinson's patients when we are coming to the topic, and you can see that, and I'll elicit and show you what exactly it is. Then there is a lead pipe. Okay, lead pipe, you will get uniform increase in tone. And next couple of things between these two, spasticity and rigidity, are like, you can put it like this. There will be, in a spasticity, there will be resistance in one direction. Resistance in one direction. Here there will be increased resistance. There will be increased resistance in all directions. Next, the spasticity is a velocity dependent. A rigidity is a velocity independent. Okay, if they ask you, you should be able to answer all these things quickly without much hesitation. All right, Next thing, VIVA has been asked on the topic of hereditary spastic paraparesis. Okay, you know the other name of this? This is also called as Tumpel-Lorraine syndrome. Okay, autosomal dominant pattern of inheritance is the most common pattern. There can be some sensory involvement also. Just read about it few lines anywhere possible. Then questions are asked on tropical spastic paraparesis. It's due to HTLV. Okay, if they ask you anything, okay, any investigation, always tell 3 important things, specific thing, okay, when it comes to spastic paraparesis. One is an MRI, another one is an EMG, another one is NCS, and if needed, do some CSF study. Then it depends on different condition. If you are suspecting MS, then you have to tell about MRI. Then you have to definitely tell about CSF to look for any oligoclonal bands. And MRI, you should be able to define the criteria, dissemination of the lesions with time and space. And then also you have to talk about NMO antibodies to rule out, neuromyelitis optica. And also you should be able to tell very clearly about other investigations of multiple sclerosis. That is, you are visually evoked potential, auditory evoked potential. All these things you should be able to tell. Okay, then there are questions that has been asked in the topic of transverse myelitis. Okay, transverse myelitis. The causes of transverse myelitis, a huge list is there. It can be due to MS, it can be due to NMO, it can be due to para-infectious causes starting from CMV, HIV, so many. And post-vaccination, almost all vaccination causes transverse myelitis. Alright, and systemic autoimmune diseases, all these things can cause transverse myelitis. Okay, transverse myelitis. Now they asked another question, what are the types of transverse myelitis? You don't need to dwell in depth of it. Just remember there are 2 types. That one is an acute partial, another one is called LETM, that is longitudinally extensive transverse myelitis. What is an acute partial transverse myelitis? It's 1 to 2 spinal cord segments are involved. LETM is nothing other than more than 3 contiguous spinal segments are involved. If more than 3 spinal segments are involved, that is called LETM. Alright, that is called as your LETM. So if they ask about the treatment in general, the treatment of spastic transverse myelitis, it can be corticosteroids is the first line. You give methylpred at the dose of around 1000 milligram IV OD for around 3 to 5 days, plus supportive care, plus acute rehabilitation. Plex can be tried. If they ask you in general about spastic paraparesis, what are the other treatment options available and what you will be doing here, always tell any case, it doesn't matter in short case, always tell patient education, counseling, and multidisciplinary team management. In the counseling for everything, see, for example, you are getting a respiratory case, you have to mention about smoking. That's what happened. I didn't mention about smoking. I got 0 in clinical judgment in a respiratory case because I didn't mention about smoking cessation in an ILD case. That's what happened to me. So be very careful. So this is very, very important. And also multidisciplinary team management. Okay, so multidisciplinary team involves your physiotherapist, your occupational therapist, your neurologist, your GP, your specialist nurses, everybody is there in case of a multidisciplinary team. So what are the physiotherapy things, modalities you will do? You will have to do some strengthening exercise, you have to do some stretching exercise, you have to give some orthosis, some cold application, and your electrical stimulation. All these things you can give. And if they ask any drugs do you give, doctor, see, for example, they give, doctors, are you aware of any drug you can give in case of a patient with spastic paraparesis? You can try some baclofen, you can try some benzodiazepine, you can also try tizanidine. All these drugs you can give. And neurosurgery, you can go for some rhizotomy like procedures. Okay, orthopedic, you can go for some tendon transfer. like procedures. So these are the things you should be knowing for spastic paraparesis. We have discussed the etiology, how to do a rational differential diagnosis. I shown you some signs. I told you about the investigation. I told you about the treatment. With this, if you've done the physical examination properly, with this basic knowledge, if you go, I think this should be helpful for you. All right, and I will see you again for my next topic. Thank you so much for listening to this, and do subscribe, and let you know if you guys have any difficulty with any topic pertaining to Mrcp as a whole for part 1, part 2 and PACES. We are more than happy to help you out in that. Okay, and if you have difficulty seeing some patients, you need some help, I am open for you always. All right, thank you guys, see you, bye bye.